Hello friends, welcome to Healthwizac Medical Concepts Simplified. In this video, we will learn primarily about non-ST elevation variant of acute coronary syndrome, that is non-ST elevation MI and unstable angina. Before proceeding to the video, let's have a quick overlook about ACS. ACS or acute coronary syndrome is a clinical condition arising due to sudden onset inadequate supply of blood and oxygen to the cardiac tissue, that is myocardium. The major culprit behind this event is either a thrombus causing complete occlusion of the coronary artery leading to tissue necrosis, also labeled as infarction, or an atherosclerotic plaque reducing the inner lumen of coronary artery, thus hampering the normal blood flow leading to tissue hypoxia, also labeled as ischemia, both arising as a result of long-standing coronary atherosclerosis. Depending upon the above coronary event, ACS can be broadly classified into two categories, that is ST elevation ACS and non-ST elevation ACS, where ST elevation ACS is due to complete transmural blockage of the coronary artery, whereas non-ST elevation ACS is due to non-transmural subendocardial blockage of the coronary artery. ST elevation ACS is also labeled as ST elevation MI, whereas non-ST elevation ACS is further categorized into non-ST elevation MI and unstable angina. Here we will discuss about non-ST elevation ACS. If you want to know more about ST elevation ACS, please click on the I button on the right top corner of the screen or click the link given in the description box below. Non-ST elevation ACS is a clinical condition arising due to imbalance between myocardial oxygen demand and supply. The major culprit behind the event is either a coronary arterial thrombosis or coronary microvascular spasm. Coronary arterial thrombosis may be due to plaque fissure with inflammation, plaque fissure without inflammation, or plaque erosion. The major risk factor leading to the event include hypertension, type 2 diabetes mellitus, dyslipidemia, obesity, alcohol and smoking, family history, age, postmenopausal female, and sedentary lifestyle. Symptoms of non-ST elevation ACS include substernal chest discomfort, either acute or recent, with crescendo pattern, that is more severe than previous episodes and occurring at rest or on minimal exertion. Pain may be radiating to neck and jaw and may be associated with other symptoms like diaphoresis or profuse sweating, dyspnea, palpitation, and nausea. Coming to the diagnosis of non-ST elevation ACS, it is primarily diagnosed with the help of three factors, that is history and physical examination, ECG, and troponin I level, where in non-ST elevation MI, the symptoms, history, and physical examination are in favor of ACS. ECG shows ST depression and T wave inversion, and troponin I level is positive, whereas in unstable angina, history, physical examination, and symptoms are in favor of ACS. ECG may sometimes show STT abnormality or sometimes it may be normal, and troponin I level is negative. Other supporting investigations that helps us in diagnosing non-ST elevation ACS include 2D echocardiography, which may show regional wall motion abnormality in non-ST elevation MI, whereas in case of unstable angina, 2D echo may come normal or sometimes abnormal. Next is coronary angiography, which helps us finding the location and extent of block. Coronary angiography may show critical partial block in case of non-ST elevation MI, whereas it may or may not show any blockages in case of unstable angina. Finally, non-invasive stress test is also a conclusive test in case of non-ST elevation ACS, but it should be avoided during ongoing chest pain or ECG is showing marked STT changes, and should only be attempted after risk stratification is done. Other supporting blood investigations include CBC, LFT, RFT, arterial blood gas, chest X-ray, and sugar levels, which helps us giving some insights about the other comorbidities. After diagnosing non-ST elevation ACS, that is non-ST elevation MI and unstable angina, now let's have a look at the management of each one of them in detail. Management of non-ST elevation MI includes 4 steps, that is rest and monitoring, anti-ischemic treatment, antithrombotic treatment, and finally coronary angiography, which helps in deciding between percutaneous coronary intervention, that is PTCA, or coronary artery bypass graft. Here, an important point should be noted that thrombolysis is not indicated in non-ST elevation MI, whereas conditions in which thrombus dislodges and gets stuck, thus converting the partial block into a complete block and giving rise to ST elevation MI, then thrombolysis can be considered, but the final call should be taken up by the treating cardiologist. Step 1, that is rest and monitoring, comprises of complete bed rest, as physical exertion can aggravate the symptoms of non-ST elevation MI. Patients should be advised hospitalization and continuous cardiac monitoring should be started at the earliest. Serial ECGs should be done, as sometimes vulnerable plaques may get dislodged and set in ST elevation MI. Step 2, that is anti-ischemic treatment, includes the use of nitrates either sublingual or intravenously, but it should be avoided in case of hypotension or the patient is having history of using sildenafil within 24 to 48 hours. Beta blockers are also administered, as it helps in reducing myocardial oxygen demand, but should be avoided if patient is having post-MI acute heart failure, bradycardia, hypotension, heart block and asthma. Calcium channel blockers like verapamil, diltiazem are also used in condition where symptoms persist even after full dose of nitrates or beta blockers, or patient is having contraindication to either category of drugs. Other additional therapy includes use of ACE inhibitors and angiotensin receptor blockers. Statins, that is atorvastatin, is also used for plaque stabilization in a dose of 80 mg stat. Some patients may also need additional agents like ezetimibe for further control in LDL levels. Step 3 is antithrombotic treatment, which includes antiplatelets and anticoagulants. All patients with confirmed diagnosis of non-ST elevation MI should be started on dual antiplatelet therapy, which includes ecosprin along with clopidogrel or prasugrel or ticagrelor, in which ecosprin is used in a loading dose of 325 mg followed by maintenance dose of 75 to 150 mg. Clopidogrel is given in a dose of 300 to 600 mg stat followed by maintenance dose of 75 mg. Prasugrel is given in a dose of 60 mg stat followed by maintenance dose of 10 mg, and ticagrelor is used in a loading dose of 180 mg followed by maintenance dose of 90 mg. Apart from this, highly unstable patients who are reserved for percutaneous coronary interventions are started on triple antiplatelet therapy, which includes dual antiplatelet therapy along with GP2B3 receptor inhibitor, that is tirofiban, which is started intravenously. In case of anticoagulants, one amongst the 4 agents are used, that is unfractionated heparin, enoxaparin, that is low molecular weight heparin, bivalirudin and fondaparinux, which comes into the category of synthetic 10A inhibitor. After the initial medical management, step 4 is initiated, in which patient is assessed for signs and symptoms of ongoing ischemia or chest pain. In presence of chest pain, coronary angiography is done at the earliest, and depending upon the CEG report, PTCA or CVG is advised. On the other hand, if the patient is not having any signs and symptoms of ongoing ischemia or chest pain, then medical management is continued. But the final call is taken up by the treating cardiologist, who decides between the reperfusion therapy versus medical management based on the patient's medical history and other comorbidities. Finally, medical management includes use of dual antiplatelets, or in case of arrhythmias like atrial fibrillation, patients are started on oral anticoagulants with antiplatelets, along with the management of other comorbidities, lifestyle modification and cessation of addiction. So these are the 4 steps in the management of non-ST elevation MI. Before proceeding for unstable angina, let's first discuss about some risk scores which are very helpful in deciding both treatment approach and management, along with likelihood of adverse cardiac events and long-term outcomes of patient with ACS. The 3 important scores listed here are TIMI score, GRACE score and HEART score. TIMI score, which stands for thrombolysis in myocardial infarction, helps in estimating mortality rates through 7 factors, which includes age, risk factor for coronary artery disease, use of aspirin in last 7 days, known coronary artery disease, episode of resting angina in less than 24 hours, ST segment deviation, and elevated cardiac markers. All factors are assigned 1 point, which gives a minimum score of 0 and a maximum score of 7, where a score of 0 to 1 point gives us the mortality rate of 5%, whereas a score of 6 points or more gives us the mortality rate of more than 41%. Next is GRACE score, where GRACE stands for General Registry for Acute Coronary Events. It predicts 6 to 12 months mortality rate in patients with non-ST elevation MI. It is calculated with the formula given on the screen or can directly be calculated through online calculators. Interpretation of GRACE score is as follows. GRACE score of less than 109 points indicates low risk. GRACE score of 109 to 140 points indicates moderate risk, whereas GRACE score of more than 140 points indicates high risk. Third is HEART score, which is abbreviation for 5 words, that is history, ECG, age, risk factors, and troponin levels, where each factor is assigned a minimum score of 0 and a maximum score of 2 points. HEART score helps in deciding active management in patients with unstable angina. Interpretation of HEART score is as follows. HEART score of less than 4 indicates low risk. HEART score of 4 to 6 indicates moderate risk, whereas HEART score of more than 6 indicates high risk. After understanding all these important scores, let's have a quick look over unstable angina and its management. Unstable angina is a variant of non-ST elevation acute coronary syndrome, which is primarily caused due to myocardial oxygen demand and supply mismatch, arising due to partial block of coronary artery due to atherosclerotic plaque. Symptoms includes chest pain, diaphoresis, sweating, dyspnea, palpitation, and nausea. Diagnosis of unstable angina is primarily done through 3 factors, that is symptoms, ECG, and troponin I level, where the symptoms are in favor of ACS. ECG shows STT changes, or sometimes ECG may be normal, and troponin I level is negative. Management of unstable angina starts primarily with risk stratification, which is done with the help of TIMI score, GRACE score, and HEART score. Patients with moderate to high risk with ongoing chest pain are advised hospitalization, and coronary angiography is done at the earliest. Patients with positive coronary angiography report are diagnosed to have unstable angina and are started with dual antiplatelet therapy, which includes ecosprin along with clopidogrel or ticagrelor or prasugrel along with anticoagulants, that is LMWH, followed by percutaneous coronary angioplasty or CABG depending upon the extent of the block, whereas patients with negative coronary angiography report are looked for other differential diagnosis of acute coronary syndrome. Patients with low risk and no ongoing chest pain can be managed on OPD basis or daycare basis, followed by non-invasive stress test. If stress test is positive, then patient is advised coronary angiography. If CAG comes positive, then patient is started on dual antiplatelet therapy along with anticoagulants, that is LMWH, followed by PTCA or CABG. If CAG or stress test comes negative, then other differential diagnosis of ACS are considered. Finally, let's have a look at some of the important differential diagnoses of acute coronary syndrome. This could be broadly classified into following categories. Cardiac causes include other forms of myocardial ischemia, that is stable angina or ST elevation MI, and pericarditis. Vascular causes include acute aortic dissection and pulmonary embolism. Pulmonary causes include pneumonia, pleuritis, and spontaneous pneumothorax. Gastrointestinal causes includes GERD, that is gastroesophageal reflux disease, esophageal spasm, acute pancreatitis, acute cholecystitis, and peptic ulcer. Neuromuscular causes include costochondritis, trauma, and herpes zoster. Apart from this, psychological causes, hyperthyroidism, and anemia can also have symptoms similar to acute coronary syndrome. So friends, this brings us to the end of this topic. Hope you find this information valuable and applicable in your clinical practice. Please do like and share this video and hit the bell icon for latest updates. And for more such informational videos on medical topics, please subscribe YouTube channel Healthwizac, Medical Concepts Simplified. Thank you.